Let's talk about the challenge that a lot of hospitals have with when they evaluate a patient who needs services around behavioral health, but they're not able to get them outpatient services right away. So often patients have to wait a very long time to really get set up with a outpatient provider. So to discuss this, I'm really glad to have with us Tom Milam, and he's a medical physician. He is the chief medical officer for Iris Telehealth, and they are really doing some innovative and really helpful work with their bridge program. So, Tom, thanks a lot for joining me.
Yeah, thanks. Last name's Milam, but I get Milam or Milam, all those things. So I answer all of them, but it's great to be here with you, Ray.
Yeah, thanks a lot. And so I've known about Iris Telehealth for a while. You guys been the telehealth arena for a while. I've paid attention to it because a while back, for about 9 years, I did psych assessments in hospitals and realized that there was a really huge need for efficient assessments in emergency rooms, urgent care clinics, community health centers, and so forth, because often patients are waiting even to be assessed. I was doing it on site for many years where I'd drive hospital to hospital and then started doing it through telehealth. And it was so much more efficient. And the coordination between the care teams was so much easier just communicating online. And I was like, wow, this is really needed. And I saw Iris Telehealth doing telepsychiatry. So maybe you can tell me, maybe you can first start off just by telling us a bit about yourself and how you got involved in telehealth, and then move into Iris Telehealth. Tell us a bit about Iris Telehealth's beginnings.
Sure, absolutely. No, I appreciate all the questions there, Ray. I've been a psychiatrist for about 25 years, and so I've seen a lot of evolution and growth in the industry, starting off in private practice and hospital work down in Wilmington, North Carolina, and then practicing overseas in New Zealand, trying to learn more about accountable care models before Obamacare came in, and then studying how New Zealand did that model similar to Canada. And then I've been on the faculty here at Virginia Tech Carilion for the last 13 years in the Department of Psychiatry, and been doing telehealth for about nearly 12 of those years. So I have always worked in hospitals doing inpatient psychiatry and consult liaison work. And certainly there's always been a shortage of providers. And sometimes before the parity laws were passed, it was because of limitations from people's insurance carriers and how you could access a psychiatrist and how many visits, and a lot of things around that got corrected with some of the parity laws. But there continues to be a shortage of providers. We've noticed an uptick in availability of providers with nurse practitioners having an easier time getting a psych certification and becoming psychiatric mental health nurse practitioners, which has been really fantastic to support a lot of the work and around the country that we do in Iris. We have psychiatrists, psychiatric nurse practitioners, and LCSWs working together. So Iris itself has been around for 10 years, almost 11 years now, doing telepsychiatry. Started here at a clinic in Virginia where Dr. Shaheen, the founder, is a child psychiatrist, started it with one clinic, just with a core model of getting great providers and getting them into clinics and hospitals and areas that meet the needs of those communities, and trying to break out a lot of the hurdles and barriers, and being both patient-centric, so doing what's convenient and good for patients in the clinics where they are, but also taking care of providers, providing a good work environment where it's not a fast-paced, pressured environment. And the fact that we've been founded and led by psychiatrists and clinicians like myself has enabled us to continue to have high quality of care and to be a great environment for folks to come work who want to do telehealth. We were busy before the pandemic happened, growing a lot, and we continue to grow and it's been fun just working with hospitals and clinics all across the country, helping them develop and grow telehealth initiatives or start them from scratch, but also working alongside existing providers to expand their care teams to provide access. I think you've been in this field too, and you know that the access to care remains a problem. It's always been a problem. So we focus on doing that as our main thing, providing access and maintaining quality work and quality of care for folks involved with IRIS.
Yeah, and with IRIS, are you all the provider, or are you working for providers? Say a hospital system contracts with you for the services, but they are the provider of the care. How does that work? And like, who does the billing?
Yeah, great question. It's the latter. So we have providers that join IRIS. So they're the majority are W-2 employees with IRIS, so we pay their benefits and their pay. But then we work and have a proprietary matching process that finds the right provider for the right organization based on the provider's skill set and interests and experience and work locations and settings. And so we match those up to have matches that are meant to be long-term. So we're not a temp or a locums agency or anything like that. We are, our model is based on showing that telehealth can be a long-term kind of arm or part of what a clinic or hospital offers to help meet the needs of their community. So they work for us. But we facilitate their work in other organizations and provide a lot of support and education as they're working from home, which they are, but working in all these different environments. So large health systems, FQHCs, community mental health centers, and health clinics, we reassign the billing to the organizations so they are able to bill for the services that are provided at their institutions and they're credentialed at their institutions so that they can collect on those receivables, but are contracted through IRIS for that work.
Yeah, that's a great way to do it, because it's much more sustainable for the healthcare organizations that need clinicians, so that they're getting those funds rather than just farming out the service and kind of losing out on that revenue, which could be challenging for them. So yeah, that's fantastic. And one of my great disappointments that I've seen with telehealth is the lack of care coordination. So often you have these large telehealth providers and they will provide telehealth services, but you have to fit into a very small box because they're not going to order labs for you locally and then review the labs and give you the report and treatment plan, or truly do care coordination with your local PCP or specialist. They kind of, if you have a particular acute need, you get a telehealth session. It's a short session and it's very siloed. It's just that one session and treatment plan, if it could fit into that small box. So the care coordination piece, I think, is greatly needed. And then with psychiatry, specifically, because such of a huge shortage nationally, patients just waiting an incredible amount of time to get in to see someone. And then again, if they do get in to see someone, if it's through telehealth, it's really hard to have the follow-up and continuity of care. So I was wondering if you could speak to those challenges and how IRIS Telehealth is working to address those.
Sure. There have been a lot of models that have evolved over the years, and different business structures, different clinical care structures, some of it very much based on one-to-one interaction with a patient, and some where it's collaborative teams working together, either co-location or collaborative care or embedded services in primary care. The fun thing about IRIS is we kind of do a lot of different things. So about a third or more of our business is working in inpatient units and on doing consult liaison work, in large hospital systems. So we might have 10 or 20 hospitals in one system, and our providers are able to go in and out of their EMR. So that's another key piece is we don't push a product, either a software EMR or a video platform. We use what the clinics or hospitals are using already, and that's meant to be a way for them to reduce costs and overhead when partnering with us. Because some places you have to use their carts or their software or their EMR. That's just a lot to ask, and it goes against our grain of collaborative care. If you're going to collaborate with somebody, then and you're going to them, it's best to use their EMR, their video platform, what works for their team. It's really important to see when you're evaluating a patient, inpatient or outpatient or consult, liaison, ED, you want to see all the work that's been done, and you want them to be able to see your work, see your notes, to communicate effectively with the team. So that type of a model is kind of what we promote. So we're in hospitals, we're working in their EMRs, at clinics, we're working in their EMRs, we're calling and connecting, talking to their therapists, talking to their case managers, sometimes interviewing patients together with them for the very point that you made, which is having a collaborative care model is what works best for patients. The community mental health centers, which are fantastic partners across the country, that model is one that came out of the institutionalization and the need to have specialized services and channeling funds from state hospitals into community mental health agencies. What I see evolving, though, is many patients wanting their care to be more holistic, so that there is less of a silo between the mental health and substance use disorder issues folks are facing and the physical health issues. So that's why we've been asked to partner with lots of F2HCs and rural health clinics and just community health centers around the country to be the behavioral health component, or and maybe they have a social worker or a case manager, but they don't have any folks that are prescribing medicines or doing psychiatric diagnostic interviews. It's fun to work in that environment and work along primary care providers as well in that environment where you're caring for them at the same time. I see that being a model that is one that's good for systems, but it's also good for patients, so that their coordination of care and communication about their whole person care is done in by one organization. We see, it's interesting, a lot of the community mental health centers that we work with are now also employing primary care providers in them for that very reason. So the whole field is evolving. The telehealth initiatives it's really the same as seeing somebody on site. They just happen to be virtual. Other than that, the care, the quality, the interaction, the communication is something that we try to replicate as much as possible. The workflows, the connecting with patients, putting them at ease, things like that you would do just as if they were in the office. And pleased to see a lot of literature about how telehealth visits, particularly in the mental health and substance use field, have been well received. And for us, it means we're saving lives. We're getting people connected to vital care. And a lot of the emergencies people are facing, whether it's substance related or some severe mental illness, it is often life-threatening, and people need access to care quickly. So it's a challenge, and with our new Bridge Care Services program, we're expanding more to try to meet some of those gaps in care.
Yeah, and what is the Bridge program that you have?
Yeah, it's created out of what we began to recognize in many partners, hospital systems as well as clinics, is dealing with wait lists. So there's an ambulatory component, which is somebody, a primary care provider, is referring their patient to behavioral health provider. And they're on those patients then often get parked on a wait list. And as you said, can wait weeks, months, if not longer, for one appointment, sometimes having to drive hours to get to where that location is. And that's kind of the way it's traditionally been. a long wait time, just like with any other specialty. So we look at that, and then we also began to see that on the hospital side, patients being discharged from inpatient psychiatry or from the emergency department or from med-surg units where they had a behavioral health component to their medical or physical health issues. Those folks and those health systems also had a hard time getting people seen in a timely manner. They might have started care. We see people in the ED or med-surg. They might have started care on their inpatient psych unit. They're discharged. But who do you see after that? And what about the medications? Primary care is often not comfortable bridging or managing that. So the concept came out of that. Many of us have been doing bridge care for years where we're carrying patients, holding them while they're transitioning from one care site to another. So that's the basic model. But being able to do it for people coming out of acute care services as well as ambulatory services has been wonderful. So within several days of getting those referrals, our goal has been to see patients within a week, to get initial psych assessment, looking at depression, anxiety, other issues going on, and then triaging them within a couple of days to see a psychiatrist or psychiatric nurse practitioner, as well as a therapist, and carrying that over for about 90 days or so on average while we're trying to work with the health facility to get that patient established with a longer term provider, ideally with their primary care provider or with their psychiatrist or behavioral health providers. Sometimes even that's challenging. So we anticipate carrying patients longer than the 90 days.
Mm-hmm. And why focus on getting them connected with a local provider rather than just continuing with them through telehealth for ongoing treatment?
Well, one of the core issues for IRIS is that we believe a lot of services for behavioral health and substance use disorders are community-based. I mean, people live in communities. They don't live in the virtual world. They live in communities. So even though we can do a lot virtually, a lot of the stressors and a lot of support services, things around social determinants of health, housing, food, paying basic utility bills, access to care, particularly for disenfranchised groups or underserved populations, a lot of that stuff works at the community level. That's why we have made a choice to work with health systems and community partners to be able to facilitate and expand what they can offer for folks that are struggling, so that those needs around social determinants of health, as well as actually getting good therapy and mental health prescribing that's high quality, getting all that together as opposed to just the silo. So we want to support the work that's being done in communities and keeping people well through that. That's always been a goal. Instead of each of those communities having to find those services locally, we can see those patients. So imagine one therapist or one nurse practitioner in a given day could potentially see people in multiple different states where he or she they are licensed. Each of those patients might be being discharged from an ED or an inpatient psych unit or an ambulatory referral, and each can get access quickly that they could never find in their home community. But the goal is not to pull them out of their community into a virtual environment. The goal is to use the virtual care to supplement and augment what the communities are able to do and try to transition them back. And we do partner with many of these communities to provide longitudinal care through their medical clinics, their community mental health centers, FQHCs. So we can sometimes transition them over to our own providers if they're employed by the local agencies there. But the goal of this is to not continue to create bottlenecks to care, which is a real problem in behavioral health.
Mm-hmm. Yeah, and some local providers are better at providing that holistic care than others. And so community health centers, the ones that I've worked with, seem to do a fantastic job with that in terms of getting getting clients, patients involved in social activities, just good health stuff, the resources that they need for their, their living, like you said, housing, food, jobs, et cetera, et cetera. And they are aware of the local resources for that. So yeah, so I think, behavioral health providers being focused on that and realizing, as you do, how important those factors are in health and continuing to get better. The other thing that this brings up, and we won't get into it too much, but standard of care. What does that mean for behavioral health? So is it the same standard of care when providing services on site locally versus telehealth? And so what I hear you saying is, well, a local community, a community health center, they are going to be more aware of the local resources. They are probably going to be collaborating more so with the supportive services, social services, church groups, social activities, YMCA. They're going to be there is going to be more of that going on. So the standard is going to be slightly different. I know with our training institute, we really push on standard of care, like provide that same standard that you would if they came to your office. If your patient has a particular need, say housing or food or domestic abuse or whatever it is, you do your homework to find out what are those local resources near them that could help meet those needs. But then the reality of that is sometimes it is different. So I really like the idea of supporting the local providers and supporting them in what they do best. Mm-hmm. And part of that is bridging that gap when there's a really huge wait. And hopefully, as a nation, we'll make some changes to increase the workforce in behavioral health.
Well, and I really appreciate that you grasp that, because it is a huge issue. There are one of our hospital partners that we first started working with came to us because they had 18,000 patients on their behavioral health referral queue waiting for appointments. And they just essentially threw their hands up and said, we are trying a fantastic health system. They're just facing that, and reached out to us. And we were able to work with them on workflow and staffing, get providers involved, work alongside their teams, reach out to all those patients, find out who needed to be seen, what kind of services they really needed and benefited from, connect with their providers to find out what kind of support they needed, and have been able to get that down to a sort of monthly manageable level of about 3,000 consults that are there at any one time, or referrals for behavioral health. So from 18 down to 3,000, and then managing that at a very large health system. We see that all across the country. So we learn from every partner. Every hospital is a different culture. Every community is a different culture. We love being sensitive to the cultural needs, the language needs, the ethnic, other needs in their communities, and find providers that can fit that, speak in the native tongues of some of the patients to help ease their anxiety about seeking care. Lots of areas that have folks that are migrant workers or refugees that might not otherwise access care. Anything we can do to keep people well in the communities where they are. And I'll tell you, a day doesn't go by that I'm not grateful for the partnerships, the efforts made by our communities and the Irish providers that support them. It's meaningful work. And that's what I love about being a psychiatrist. It's been 25 years, and I still feel like even on days where I'm frustrated and tired, we're still making a difference that is a meaningful impact in the communities here in Virginia, where I am, and across the country. So we'll keep at it.
Yeah, such a important piece of career, the meaning making, and absolutely great career for meaning making, connection. Yeah, making a difference. Yeah. So Tom, thank you very much. This has been very helpful, and thanks to Iris Telehealth for all the work that you're all doing.
Yeah. Thank you for having me, Ray. It's good to be with you.